introduce. My name is Peter Forsberg. I'm an assistant professor at the University of Colorado. I'm a plasma cell disorders specialist, so I'm excited to learn about lymphoid malignancies from our wonderful panel of experts today. We really have a world-class group of providers here to share information on a number of interesting cases. So I'll ask them to introduce themselves. Dr. Pagel.
I'm John Pagel. I am not a plasma cell specialist. I actually focus on lymphoid malignancies, really exclusively do research and, of course, patient care in lymphomas and CLL, and I'm at the Swedish Cancer Institute in Seattle, Washington.
Hi, I'm Michael Thurman. Thank you very much for inviting me to participate in this tumor board. I'm on the faculty at the University of Chicago, and I specialize in lymphoid and myeloid malignancies.
Pleasure to be here again. Thank you. I'm David Schuster, and I'm a radiologist. I'm Division Director of Nuclear Medicine at Emory University in Atlanta.
So this is a 61-year-old male with relapsed classical Hodgkin's lymphoma. Patient presents with fatigue and neck swelling at this point, and our primary question is going to be, what is the recommended treatment strategy? So in this situation, the patient recently noted fatigue and neck swelling, and a planned surveillance CT scan was moved up. Patient has an ECOG performance status of 1. Medical history, notable just for hypertension. The patient is an active smoker with a 35-pack-year history, no other alcohol or illicit drug use, no really contributory family or social history beyond that. In terms of their oncology history, in late 2019, the patient was diagnosed with stage 1 classical Hodgkin's lymphoma with a left cervical lymph node involved. It was less than 5 centimeters with a normal ESR, no unfavorable features except for the patient's age. They underwent 2 cycles of ABVD with a subsequent complete metabolic response by PET-CT. They did receive consolidative involved field site radiation therapy, 20 gray, to the left cervical lymph nodes. So at this point, in the setting of the new neck swelling, they underwent some planned imaging, and I'll let Dr. Schuster discuss with us.
Sure. The images that we're going to see are going to show bilateral cervical lymph nodes, but there are also extensive adenopathy, which is FDG avid, below the diaphragm as well, including porta hepatis, porta cavo, parodic, and hilar mediastinal as well. And we could see that in the cervical nodes that the uptake is what we call a Deauville 5, which is the highest. Deauville is a 5-point scale, you may say, which has been standardized. And the highest uptake is markedly greater than liver and or new lesions. And trust me, this is markedly greater than liver.
Perfect. So the patient now underwent a right cervical lymph node biopsy, which demonstrated classical Hodgkin's lymphoma. Tissue cores showed effacement by a population of small lymphocytes with rare larger cells and scattered eosinophils. The larger cells were positive for CD30 and 15 with IMPAX5 staining. They were negative for CD20 and CD79A. In terms of labs, patient's CBC demonstrated a white blood cell count of 13,200, hemoglobin was 10, platelets of 292,000. They had normal renal and liver function. They did have an elevation in their lactate dehydrogenase. Otherwise, screening studies demonstrated normal transthoracic echo. Pulmonary function tests had an FEV1 of 70% and a DLCO of 86%. So at this point, the primary question is, what would the recommended treatment strategy be for this now relapsed patient? Dr. Pagel, I'll ask you to what you think would be the next steps.
Yeah, well, this is, of course, something we don't see a lot of. We, of course, don't see a lot of because we cure most patients up front with standard therapy when they have stage 1 disease. And this patient actually had what looks like relatively favorable disease. So this relapse presentation is worrisome. Now, I think there was about a 2-year remission after standard therapy, combined modality, of course, again, the ABVD and then risk adapted and followed subsequently by the involved field radiotherapy. But the 2-year remission, while encouraging, is worrisome to me given the extensive relapse. disease above and below the diaphragm. This is pretty widespread disease, obviously, and that does make me concerned more about this patient than I might be with someone with more of a local recurrence. Clearly, this patient needs aggressive therapy. I believe he's around 61 years old. He does have a significant smoking history. If I remember, that was about 35 pack years, but recent, and you showed us some pulmonary function tests that suggested that clearly he has what is likely adequate pulmonary function to have aggressive treatment. And for me, and I think most people, the algorithm here is if the patient's a transplant candidate or not. Still, the standard of care is to try to get these patients to an autologous stem cell transplant, given the chance for curative therapy. We do believe that we cure about half of patients that we can take to transplant. And I would work hard to get this patient to a remission or at least chemosensitive so that we could roll into an autologous transplant. What the treatment strategy is to get to that transplant, I think, is very debatable, perhaps becoming actually interestingly controversial. The standard has been, of course, cytotoxic chemotherapy. Perhaps the most commonly used regimen is the ICE regimen. I use a lot of that myself, but of course we have many other salvage regimens that can be used. And I would think that as long as you're getting chemosensitive response and hopefully even achieving a complete remission, it probably doesn't matter how you get there. We just want to get you to that transplant with chemosensitive disease. So I commonly will give these patients a couple of cycles of ICE, reevaluate. After the two cycles of ICE, I'll collect the stem cells coming out of that regimen, put those cells into the freezer, re-PET scan that patient and see if we're able to roll into a transplant at that point or not. I'll just mention before we go on that there are a lot of other salvage strategies, and in particular for people who might be a bit older or can't really tolerate standard therapies. We now actually have data that suggests that even if you can get a remission with a novel therapy, such as brentuximab vedotin, or with a PD-1 inhibitor, nivolumab or pembrolizumab, that actually those patients can do very well with a transplant as well. And there are actually even really outstanding early data that's been reported of combined therapies with one of the novel treatments and with chemotherapy-based regimen, even in the relapse setting. And I think we'll talk more about that kind of stuff in the front line. But there's a lot of approaches, and I think the most important thing to remember here for a patient like this, who is still relatively young, he's 61, is to try and cure this patient with a transplant.
Perfect. Thanks, Dr. Pagel. So, in terms of the summary, so in this patient is in their early 60s with a early relapse, I guess a relapse about 2 years after initial therapy, with now extensive disease. The goal would be a curative approach targeting getting the patient to an autologous stem cell transplant, thinking that leads to about a 50% cure rate. The thought would initially be more intensive chemotherapy, probably with ICE or 2 cycles, collect stem cells off of that. But you have treatment options in terms of, some of the more emerging targeted therapies like brentuximab vedotin or PD-1 inhibitors as well.